Everybody, thank you very much for listening to us and choosing to come for this session. My name is Vento Auma. I work as an independent consultant, but I have a strong affiliation to the SPEED project and Makerere University School of Public Health. So I participate in a lot of the activities that happen there. I'm going to present a study that, a report that we wrote and a book chapter that we contributed to, and it was published as one as a chapter in the SPEED website. You can look for the book on decentralization and universal health coverage. I am standing here as representative of many other people who made contributions to this writing. The lead person was Christine, who is here today with us, and the others are Suzanne Chiwanuka, Aloysius. We had also Professor Freddy, Timothy Musila, and Sarah Biachika. So this is, I use this? How do I use it? This is? Okay, so this is just illustrating that we are on chapter 6 on the book on universal health coverage, and it is on the SPEED website, which you can all access at an appropriate time. Sorry. And this is the outline of my presentation this afternoon. I'll give you a brief background of the writing, and then we'll go through the methodology, and then look at some of the recommendations. This is just a brief outline of how it is structured. So, again, following closely with what Christine has just been discussing, we are talking about decentralization and universal health coverage. And in this context, we're looking at decentralization as a form of governance involving the transfer of authority from the center to alternative institutions. And it's been promoted in lower and middle income countries because it is looked at as good ways of improving efficiencies, equity, and promoting accountability, and also encouraging local participation and ownership for service delivery. A universal health coverage is the aspiration that all people should obtain health services they need of good quality, and they should not have financial hardship in the process of looking for health care. And for us to go to realize universal health coverage, strong health systems are required, including governance structures and systems at all levels of service delivery. So the team looked at this we used this methodological model to review the functioning of the decentralization in Uganda, and our focus was more on the model as it is, but we used the national and policy institutional framework, the environment in which decentralization is functioning, and including capacity and enhancement, to kind of look and see if it was helping to ignite actions in terms of empowerment, including good leadership and governance at the local government or at all levels of governance. And then we looked at it in terms of service delivery. And then we reviewed it to see if it was giving us the outputs or the impact we wanted from the process. So this is just to explain to you a little bit more that this is therefore how we reviewed the functioning of decentralization in Uganda, focusing on these four elements, and then seeing if it has made contributions to the outputs that we want. So the implementation of decentralization in Uganda is functioning within a legal and policy frameworks in the sense that we have the constitution of Uganda, which is the overarching framework within which this country provides services and the functioning of political systems. And then at the local government levels, we have the Local Government Act, which gives provisions for operational processes. And these are supported by other instruments that function to fill in and enhance the functioning of the Local Government Act. In Uganda, the model of decentralization being practiced is devolution. And in this case, emphasis is at local government levels where districts are the units of implementation of services and also of political activities. We have the Local Council 5, which is the chairperson and overall head of the districts. Districts can and local governments can make laws and bylaws and function within the constitution as constitutional provision. In terms of resources, our framework was also saying that we need resources for decentralized services in order for us to realize its objectives. And so in terms of resources, funding for decentralized services were mainly from government sources, which is the conditional grants, and also the unconditional grants, donor funding, and also locally raised revenues as provided for in the Local Governance Act. The Local Government Act also authorizes districts to raise additional resources, and this could be through graduated tax, property tax, school fee, user fees for health facilities, and then education fees. The other resources required by decentralized health service, decentralized services are human resources, commodities, and in this case we have the district service commissions and supporting issues related to human resources for health, and then we also have support systems from the procurement and disposal systems for acquisition of goods and services. In terms of capacity for decentralization in Uganda, in 1992, the Decentralization Secretariat was formed, and this had the mandate for training both political and also technical leaders. They produced manuals and guidelines for supporting the implementation of decentralization. And they took on routine supervision, monitoring, and mentoring at the start of decentralization to enhance capacity for local governments at that level to be able to carry on the activities that they needed to do. So this slide just gives us a snapshot on what happened. From the time that the concept of decentralization came on. It first started with, in terms of law, there was a local government statute that was passed, and this was in 1993, and at that time we only had 39 districts in this country. Then in 1995 we had the constitution, and during this time we only had 45 districts. We had the first presidential elections at that time. Remember, in decentralization we are talking about both political processes and also management and administrative processes that are important for service delivery. Then in 1995 we also had, in 2005 the constitution was amended, and this amendment allowed for the creation of regional governments, which is related to local councils 4. In 2005, cows that used to be employees of local governments were decentralized. The graduated tax was abolished. At this time, we had about 69 districts. Then in 2011, and to date, we have had also additional presidential elections and parliamentary elections. And right now, we are talking about between 112 and 135 districts. And local government elections have also been happening. So what is happening with the decentralization and the Uganda health system? The institutional framework is such that at the start of decentralization, the Uganda health system was functioning within the PIP. And under PIP, health was really a high priority agenda for this country. And we were guided by the national health policy and also the health sector strategic plans. And within this, as mechanisms for propelling health service delivery and further decentralization, we have the health sub-districts. And then we had the mechanism for delivery of the minimum healthcare package aligned through the tier of service organizations for this country. And then the community interventions are being done through village health teams and hospital boards. Other related reforms that were there at the start of this decentralization was the issues of user fees that was eventually abolished, but also the health sector was functioning within swaps, which was a basket mechanism of putting all donor funding together in order to support the health sector. And then there was also the PPP, the public-private partnership in health, was also the policy and institutional system was put in place. This is just to kind of relate the previous discussions that we've had, that in decentralized health system, the intention was to have both political and administrative systems kind of relating and closely relating to health systems and providing the necessary health services. Which one is the pointer? Yeah. So here is just to try and relate this management and administrative processes within the districts with the health system structures. In terms of capacity building for decentralized health governance, training programs were made available for district health managers and district health teams. There was strong supervision mechanism from the Central Ministry of Health in terms of monitoring and mentoring, in terms of quality assurance teams, planning teams, and eventually area teams. At facility levels, there was the yearly staff program for quality assurance at health facility levels. And the health information system was also introduced and later upgraded to health management information systems. The SWAPs and the PPP systems enabled...
2 minutes. The next session is very near the plenary, so you try to hurry up. We have 2 more presentations. And it's 3:30 already.
It's already starting. Now I get confused what else to do. Okay. So, in terms of the realities of change implementation, okay. So the decentralization was introduced to enhance service delivery, and it was introduced within certain principles. But as implementation carried on and we got on with the implementations, some things changed. Some things changed. For example, we are now functioning under the National Development Plan from the PIP. PIP prioritized health service delivery, but right now the National Health Development Plan is prioritizing, for example, infrastructural development. There has been marked increase in the numbers of districts. We had from 39. Now we are at 135, and these ones have implications about issues of supervision, issues around duplication of services, and issues of missing regional administrative structures from the political system is also affecting some of the intentions of decentralization at that point. These are also additional changes that happened within the decentralized, in the implementation of decentralized health services. Right now, we are, for example, looking at re-centralizing of essential health commodities from the districts gone back to the national medical stores. These are very demoralizing actions for district managers. Some cadre are beginning to also advocate and indicate that they want to be re-centralized, for example, medical officers, and this go beyond against decentralization principles. There have been changes in the supervision monitoring. Right now, we have very many parallel programs in the districts. The tools like the district league table have been maintained. Swaps seem not to be functioning at all. So did decentralization help us in achieving health system agenda? Yes, somewhat. Political leaders have been chosen by the population. We have some structures and systems for community actions, which is one of the intention of decentralization. We have inadequate capacity at community levels to effectively participate in health services, in health systems governance. In terms of service delivery, yes, some modest achievements were made, but issues around access by communities to actual services remain low. District managers are lowly motivated and are not very excited about their work anymore. Political and managerial accountabilities still remain. So, in terms of lessons and conclusions, there's been difference in the design and implementation of decentralization, but we did not take into consideration, or we did not proactively look within the system to probably review it midway and say what are the issues that needed to be attention paid to. There is mismatch between political and technical authorities at decentralized level. We did not take consideration into the contextual changes that were happening. And resources for decentralized health governance, well, was made available, but the control of finance and human resources were retained mainly as central government and development partners. So overall, there was modest achievement of decentralization in the Ugandan health system. So going forward, what do we need to do? This is the last one. Going forward, what do we need to do? I think at the general decentralized system, there's need for a review of the reform in its all, to see issues regarding fiscal decentralization and issues regarding decision space, especially at local government levels. There's need to look at probably an intermediate administrative system at the regional level. And then for the health system, there's also need for a comprehensive review of some of the strategies that were being employed, for example, the health sub-districts, probably another look at the regional governance, continued work on capacity building, and most especially a multi-sectoral approach from the start, and how to respond to the decentralized health system. Thank you.
Thank you very much.